Wonderful. Well, welcome everybody to our Super CFAR seminar. This is the first one in 2025, and it is with great pleasure that I welcome today's speaker, Dr. Shannon Smith-Bernardin. And Dr. Smith-Bernardin is a registered nurse by trade and a nurse scientist, consultant, educator, and healthcare practitioner. She is an associate professor in the School of Nursing at UCSF, specializing in alcohol use disorders, sobering center utilization, emergency medical and community-based program collaboration, and homeless-related research. She is a co-founder and the first board president of the National Sobering Center Collaborative, which is a nonprofit aimed at identifying and developing best practices, standards, and education towards the use of sobering centers for the care of individuals with substance use. And I also want to share that Shannon is an alumni of our School of Nursing PhD program. And so it's been wonderful just watching her career and trajectory accelerate over these years. And it's an honor to have her present her research today. I will pass the baton to Dr. Smith-Bernardin.
Excellent. And I will start screen sharing right now as I start chatting. And hopefully, there we go. Should pop up everybody right there. Does that work? Boom.
Looks
All
great.
right. Beautiful. So thank you so much for the introduction. So I am Shannon. I'll do a quick shout out first, just doing land acknowledgement to the Ohlone people who have originated in this gigantic area that we see as the Bay Area, all the way down from Gilroy, San Joaquin, up over Oakland, Mount Diablo, etc. And if you have not checked it out, especially if you live here in the Bay Area, the Shumi Land Tax is a nonprofit that is women run by the Ohlone tribe populations, and they do everything from buyback of land, etc. And you can pay your land tax every year or just one time from some money towards being here on the land. So I wanted to throw that out there. So I am a registered nurse. I started working, got my license in 2006, did the doctoral program, and most of my work has been, I started over at San Francisco General, has been in medical respite care and sobering center care clinically in Department of Public Health. So I was there, we'll chat about that more. Street nursing, doing a lot of work on the intersection of individuals with alcohol use disorders and experiencing homelessness. And obviously it's a Venn diagram that does overlap, but it's not everybody who's experiencing homelessness has a substance use condition and vice versa. And my quick disclosure is I am funded by the National Institute of Health via NIAAA grant. It's a K grant, so it's one of 5-year new researcher type grants. And that is something I'm in 2.5 years into the middle of, and my work with the National Sobering Collaborative is unpaid. So, there we go. Oh my gosh, I skipped one. I wanted to start off with the NIAAA definition of recovery. So in case you hadn't seen it, but it's been almost 3 years now, for the first time, the federal agencies started basically reframing and finally kind of catching on to lots of us who do this type of work, from harm reduction, substance use, direct care services, that we have way more expansive definition of recovery than just abstinence. And they officially changed that, SAMHSA and IAAA. Looking at recovery is basically the remission from diagnosable alcohol use disorder and the cessation from heavy drinking. And those two things happen and exist over time. So the individual is able to take care of themselves on some level. There's improvements in who they are in terms of physical and mental health, their quality of life. And ideally, they've been reconnected a bit into community, society, et cetera. And that's it. It doesn't mean that they've ever had to have cessation of alcohol use, as long as some of those areas have improved dramatically. So what I want to talk about today is we're going to go through basically sobering care. What is sobering care? A little bit about it on the national level, comparing it slightly to other things that exist from detox, shelter, et cetera. And then I'm going to dive a bit into a few different programs, and especially with the focus on individuals who are at risk of acquiring HIV, hepatitis C, other conditions such as that can be transferred that way, and individuals who are experiencing homelessness, et cetera, how different programs, specific sobering centers themselves, have different things that they're doing that could help work with individuals with chronic disease, et cetera. And we'll dive into that as we go along. So what is sobering care and why are we doing it? It's basically an area that individuals who are experiencing acute intoxication, typically alcohol and or other drugs, can go in to sober up for a short amount of time. And we call it clinical or functional sobriety, where they're able to take care of themselves at the end of that visit. And it could be about 4 hours, typically to 12 hours is the anticipated length of stay. For individuals on certain types of drugs, for example, some stimulants, if they are coming down off a 2.5, 3-day run, they may need 36 hours to sleep it off. And they'll kind of get up every few hours, maybe be a bit more stimulated again, but then come back down. And so that's the type of environment we're trying to look at in relief of getting people out of the criminal justice system. They don't have to go to jail. They don't have to get arrested. And they don't have to necessarily go to the emergency department unless they need it for a higher level of medical care. And so we're looking at getting these individuals themselves a benefit from not having those risks, and then also having other parts of the community, such as the jail, not be overcrowded with individuals. And there's somebody is it me? There's someone who's unmuted. And I'm trying to figure out it's making a scratchy noise, and I just don't want the recording to end up grabbing it. You can totally I just wanted to throw that out there. So, sobering care. When I first started, so this was the cool part. So I was with San Francisco Sobering Center. I started in 2007. It was when the medical respite, medical shelter had opened. So it's been a very long time, which is kind of crazy to me, even thinking about this. When I first started, people would call me. Some folks would visit from other communities. I'd heard about other sobering centers, but it was like I heard about the Portland program and San Diego program, and then Houston had come out and visited when they were starting their program. But the reality is you couldn't Google and say, where these programs exist. Also, nobody could tell me, how did you define sobering care? So I ended up, at that point, getting in touch with some researchers who had done work on ambulance triage to alternate destinations. So it was very early work, very much more theoretical than practical, and got a hold of people who published papers. There was 3 of them. And 2 of them ended up connecting with me. They had a conference in Seattle that was 3 weeks after I had emailed with them from my first year as a doctoral student. This was back in 2012, 13. And they were like, oh, we're going to Seattle for a conference in 3 weeks. You should jump up here and join us, and we can meet face to face. And at this conference, we'll just rally people who want to talk about sobering care and specifically emergency department. It was the American College of Emergency Physician Conference. And so I went up and joined them, met everybody. We had our first official meeting of people who talked about sobering care, and it was fantastic. And we just kind of kept going. It was 2 individuals, Otis Warren and Melanie Littman, who are ED physicians out of Brown University. And we progressed to ended up starting this National Sobering Collaborative. And now part of the work that we've done is identify sobering care throughout the country and in North America in general, about 11 programs in Canada, the rest of the United States. And it's, I think, the only part of harm reduction related to substance or harm reduction in general that the US is beating Canada at. And I say that loosely, that we're beating anything regarding Canada's work in this world, but we really have progressed tremendously in the last couple of decades in this area. And when you look at sobering care, it's not treatment. It is a safe space for people, and the one visit for 4 hours, maybe the only time they ever visit, and that is a success. They come, they stay for a few hours, they get a shower, maybe they get a new sweatshirt, they maybe get a meal, and they go about their lives. But we don't do detox. It's not social detox or medical detox, where the goal is removing all the substances from the body entirely. And that can take a couple days to 2 weeks, depending on the person's use. It's not treatment or rehab. The focus is not on abstinence. It's also not sober living, where there's a little bit of confusion. One of the comments that we keep talking about is sobering the right word for this? Probably not. And I'm going to probably have to find a new name for my nonprofit. And all of us are trying to figure out what name we can use for this sobering care that is specific to what's happening, less confusing to other things, but also better understood. So when you tell someone you go to sobering, they don't actually know what that means. So if anyone's got good ideas, feel free to put that in the chat. And where does it fit? So when you're looking at sobering in the continuum, we are really kind of a hub in the middle of all different community services. So typical referring parties will basically identify an adult, typically 18 years and older, some level of intoxication, who is unsafe typically in the space that they're in. So they're outside in public, they are, whatever the nature of the call is for law enforcement, maybe they're panhandling, maybe they found them, they need to take them to jail, but they don't want to take them to jail, they'll take them to us. Homeless outreach teams, and we also take lots of walk-ins. The part where my research mostly focuses on at this point is direct ambulance alternate destination. So a 911 ambulance shows up on the field, they see someone who's intoxicated, do an assessment, feel that the individual does not need to go to the emergency department for a higher medical need, they can bring them to sobering. Very few programs at the moment in the United States. Of the 80 or so in the US, we only have 5 or 6 or 7 that take directly from ambulances. There's 5 major players in that game, which we can talk about more later. It's lots of different logistical, regulatory, and legal aspects to ambulances going to a sobering center, but it is possible and it can happen. We work in prevention in terms of someone comes to us once, hopefully they get a connection with a peer level staffing, which is probably one of the best practices we have. Individuals who have experienced recovery, experienced a criminal justice system, experienced some level of homelessness, or they've been in the world. They get to engage with these individuals, and then also referring to linkages, placements, go to detox, go to sober living, go to shelter, go to urgent care, etc. And the main things, and we won't read through all of these, but it's basically a very low barrier environment. I described earlier, 18, no medical complications. Their behavioral health situation is nonviolent and able to be de-escalated. Doesn't mean they have to sit still and be quiet. It just means that they have to be de-escalated enough that they will not cause harm to themselves or other people while they're in the sobering center. And sobering brings together what we want is what I consider sobering care, and we've defined it this way with the National Sobering Collaborative, is these community partnerships. You have to have ways to be able to get people to other programs, has to be safe, monitored, and very flexible to the community itself. So if your community has a lot of methamphetamine use versus alcohol or opiates, then it should be able to be flexible enough to engage with individuals with methamphetamine use so that they can be successful in this program. And again, the short term, under 24-hour length of stay is very typical. And with the staffing, it's varied, but the most common is some level of medical staffing, EMT basics, nurses, etc., and or peer level individuals. So certified or registered drug and alcohol counselors, case managers, individuals who have lived expertise, who are working. Those are the 2 main staffing. And then there's the logistical stuff, the admin management. I always recommend for programs that they have some level of RN who ideally, all LCSWs can be excellent at this also in terms of overseeing kind of the management of the program and how it integrates with the community, because the social work model and the nursing model really do have a very holistic approach to how patients and individuals interface with everything else. And then it's kind of a mix from there. It could be very simple program, or it could have case managers, nurse practitioners, hospital liaisons that go back and forth, community paramedics that stay on site, etc. It's very varied based on the budget and the populations they're looking to serve. And then typically monitoring, making sure people are safe, emergency protocols, and then all levels of different ways to make an individual, one, feel accepted and feel comfortable being in the environment. And that could be doing their laundry, offering snacks. Everybody should have their own bed or their own chair or their own cot, whatever it is, they should have a space that is theirs by the time that they are there. Very original, some of the original sobering centers and what we typically see in drunk tanks in the jail is it's a big space and it is not typically monitored, but it's also a situation where many individuals they're basically just laying on the floor. And that is not acceptable or appropriate for one who wants to provide sobering care. And it's not a good way to engage with a person to make them want to hopefully feel a little bit better about themselves and hopefully have a lot more desire to change their behavior so that it has less harm. So looking at some individual programs, just wanted to open up in case there was any quick questions on anything I've said so far. Feel free to, I don't see anything in the chat right now, but if you'd like to ask a question, feel free to raise your hand and or unmute and let me know. I love doing this whole slide sharing thing in the middle of presentations because I have so many windows open. All right, so, oh yes, is it Caravella? Is that how I say it?
Yeah, that's right. Sorry. Hi. Hello. Could you just say again, I know you just did, but the difference that you see between sobering centers and detox centers?
Yes. So I consider sobering kind of pre-detox. And sobering centers are basically the time where they are at risk for harm due to their intoxication itself. And this could be harm from the elements, harm for going to, like, they're going to go to jail, they're unable to take care of themselves. And so we are taking that time to basically get them through that acute intoxication stage. Then detox, and this is where the confusion often happens. There's two different kinds of detox. We've got social detox and medical detox. Medical detox, I'll start with first. That's typically when we're anticipating people have some level of physical dependence to the substance that they're using, and their body is going to go through a withdrawal point where they potentially or likely need medication. Alcohol would be Ativan, Librium. There's a few other medications that folks can use, whether or not it's provided in the community. So they might do medication so they don't have seizures, so they don't die, so they don't have really bad withdrawal effects. As many of you likely know, alcohol is opiates, and with the benzos in particular now have a similar profile. But alcohol can be fatal if someone stops drinking, if their body is dependent on it, mainly because the brain is washed in a depressant, aka alcohol, to the point for so long that the brain just kind of stops producing as much of its own depressant neurotransmitters. And so now when you go to detox, there's no alcohol left on the brain. And now the brain has all the stimulant going on, and it takes 48 to 72 hours for the brain's depressant neurotransmitter production to catch up to the level of neurotransmitters that are stimulating. And so that's kind of why withdrawal happens. I know I just went in the weeds there, but I love that concept. With the confusion is the fact when sobering centers first started, it was 1971 with the Uniform Alcohol Act in the United States, and it created sobering and social detox together. And it was both Canada and the United States had very similar bills in 1971. And so they had this idea that they could put sobering, they take people intoxicated and then keep them for 3 to 5 days of social detox all together in one model. And those two entities started splitting. Most communities got rid of the intoxication component and only wanted to work with people that were no longer intoxicated, that were just starting to go into withdrawal, to go into social detox. And because of how this was all started 70 years ago, despite it being 50 some odd years since, that confusion has still not really been teased out. So that was a long answer to your short question. Hopefully it was helpful. All right. So let's dive into some individual programs. Start with my alma mater first, San Francisco Sobering Center. So we have with the SF Sobering Center, it was created in 2003, and it was the first program in the country that, or the point of the San Francisco Sobering Center was to divert individuals who were taken by ambulance to the emergency department so that the ambulances could take them to the San Francisco Sobering Center instead. So we have been accepting from 911 ambulances in San Francisco Sobering since October 2003. It's been a long time. There's over 20,000 encounters directly from EMS into the Sobering Center here. And the best data we currently have in the country is on ambulance transports to sobering is out of San Francisco, with Washington and Austin slowly but surely catching up to us right now. And so when we are looking at the sobering center itself, so let me go to this first. So medication management. So a couple different things that when we're looking at with the San Francisco Sobering Center in particular, they did anticipate and were correct that most of the individuals who are going to be coming into the Sobering Center were people experiencing homelessness, and or people who had fairly moderate to severe regular alcohol consumption. And so when we're looking at San Francisco, it's around 70% of the unduplicated clients, 70% of the individuals themselves are experiencing homelessness at the time of their intake. And when you look at, so that's out of all just the individuals themselves, around 70%. If you look at the encounters, anyone who's visited like 3 or more times at the sobering center, it's 100% are experiencing homelessness at the time. So most people who are housed come one time and we don't see them again. For the folks who do come to us more frequently, with the medication management side of things, we offer withdrawal management because there was often a wait to get into a medical detox program, which I think now our county's officially lost our medical detox, like most counties locally. And so we can actually start people in the San Francisco Sobering Center on out of equilibrium to start the alcohol process for medical detox / withdrawal management. It's not a detox itself, but for people who've been accepted into detox, we can start the medication management so they don't go in withdrawal at 2 a.m. while waiting for their 9 a.m. bed. We can get them through those few hours and get them over that point. This is in collaboration with the medical respite program, which has nurse practitioners. We have standing orders, so they just literally put in the patient's name, check off a few boxes. CBHS on Howard Street, the Community Behavioral Health Group, provided the medications through a state grant. And so we literally have just able to have medications on site at the sobering center that don't have to be retrieved from the pharmacy every time we have somebody have a med. The addition in what we do is a lot of folks with chronic acute care management. So these are individuals that we see a lot. We started this about 10 years ago. And I keep saying we, I don't work for them anymore, but it's hard not to say we. So I will try not to, but it's whatever, that's what I do. So this is for individuals who would come in all the time, from 2 or 3 times a week, 200 times a year. And they had diabetes that they were maybe on medication for, they had heart conditions, they were on a variety of different meds for chronic disease, and or they had an acute situation going on, such as a wound. A good example is a gentleman, he'd gotten a bilateral bacterial eye infection. And of course, they're not going to keep him in the hospital for that. And even if they wanted to, he didn't want to stay because he wanted to leave and drink. And so it was supposed to be cured, treated within 2 weeks with basically direct ointment into the eye. And we got the ointment, and it took 6 weeks, but we were literally able to clear a bilateral eye infection by giving him his antibiotics at the sobering center every time he came in, and we'd encourage him, just walk in anytime you want. And so we do a lot of work with this for well-known clients. And so folks who never had any medication before are now getting their meds at minimum 3 days a week. And others are just walking in, they'll get a snack, they get their meds, and they can go about their day. And that might involve drinking, that might involve other stuff, but they're able to get that medication that they never would have had before. Looking at Sun Street, this is down in Salinas and Monterey County. Their sobering center is adorable. Like, it's this house in the middle of a neighborhood. It's directly across the street from a school, which did have a lot of NIMBYism, and not in my backyard, which I think with all of your work, you probably have experienced some of this concept. But they were like, we still want to make this happen. And it was adorable. Their rooms, they had one room for men, people identify men, one for women. Then they had a room for, anybody. Blue buckets were in the men's room, pink buckets were in the girls' room. I put this in quotes. And then they had purple buckets for the, however else you want to identify, here's a purple bucket for you. So it was kind of cute. And the clients actually loved it a lot. They have a first offender DUI program. Some folks find this controversial, but let me finish my sentence first. So many sobering centers now are working with like California Highway Patrol or other states, whatever their equivalent is, of individuals who are getting pulled over who are driving while intoxicated. Obviously, most of those individuals are not experiencing homelessness. And so it's usually first offender. Some programs will accept people again later. They didn't crash the car, they didn't have an accident or anything of that sort. They just got pulled over. And so they can actually be brought directly into the sobering center instead of going into jail. They still get arrested. They still have to go through the entire process that is involved around with driving while under the influence. And that includes like the $15,000 fine, the record, having to go to giant treatment programs, et cetera. But instead of going to jail first and just being shimmied off, they start at the sobering center, who most of the programs can get them directly into a treatment program that can start immediately. Like literally the moment they can leave, they can walk into a residential treatment program, and or such as Salinas, they have an 18-month program. People can be enrolled in it, and they have constant follow-up with the individual. And then they also help them case manage them through the legal process, making sure they go to their appointments, they know what's supposed to happen, and then they can get the care that they need. And ideally with the goal that they engage in the system of treatment and community support immediately, versus just getting the legal ramifications of it and not necessarily changing the behavior around their substance use that caused them to be drinking and driving or using a substance in the first place. Austin. So the room, I like to show this picture here. Austin Sobering Center has, rather than having gender-based rooms, which many folks do, they're like folks who identify male versus female, that's the dorm they go to. They started having an increase of methamphetamine and stimulants in the area. So their dorms now are split into stimulant versus depressant, and kind of where the presentation of the individual and what they most need. Do they need to sleep on a bed and rest for a while? Or are they still kind of up? They just need to be inside in a safe space. And so this room is a photo of the wall. It's all painted. It's a beautiful room of the stimulant room. They've got couches, they've got bean bags, they have a whole shelf and games, they have coffee, and basically just, it's like the fidget spinner room. They just, people can hang out, they can be safe, they can chill out. They have found that individuals that they might be holding for like a little bit longer period of time, like they finish sobering and they're waiting for a day to get into a treatment program, will often hang out in the stimulant room also because it's well lit. The depressant room is just kind of beds on the ground, nothing too exciting. The other thing that I'd love to point out with the work that they're doing is, yeah, that shows up fairly well on your screen. They do their triage when people come in. Austin's one of the programs who takes directly from 911 paramedics. Their main staffing is actually EMT paramedics. So it's paramedic handoff to a paramedic. And they do their triage severity level based on often the drug of choice that comes in. Many sobering centers do, like you can see the alcohol level, they will do breathalyzers just to kind of figure out where the person is. And wherever they fall on this level 1, 2, or 3, the vital signs included in this process changes how they're monitored, and they can obviously flux between these two. And as you see, someone could come in and their monitoring status will be every 15 minutes of an actual hands-on assessment. Throughout sobering care, and this is one of the standards that we have, minimum of every 15 minutes of eyes on someone to make sure they're okay in any sobering program. Most sobering centers have windows that either staff members are sitting at desks in the clinical space or in the dorm space, or they're able to see through windows to pretty much every bed. That's kind of what we expect for sobering care nowadays. Mission Street Recovery, they do have a new space that moved across the hall, but I didn't have a new photo to make it work with this presentation just yet. They have lazy boys. And the cool thing with Mission Street Recovery Station, they're down in San Jose, is they have really incredible law enforcement collaborations. The organization that runs the Mission Street Recovery Center is Horizon Services. Horizon has 3 sobering centers now: San Jose, Alameda County down in San Leandro, and we just opened a new program August 1st up in Chico and Butte County. So it's one of our first rural ones that I've been a part of helping start. I work with these guys as a consultant on a regular basis. So they are placed in the reentry center. And so folks who are coming out of jail can come right in to the front desk. And if they're looking for a treatment level thing, or sometimes the jail will discharge them with the idea that they're coming to the reentry resource with a note that says this person's getting into treatment, and they'll send them over to the sobering center. The second thing with their law enforcement collaboration is they're on the same campus with their crisis receiving program for individuals with mental health. And so folks with mental health only, no substance use at all, and or drug use only, can come into the sobering center there also. The thing in this stat is very similar to what we see with lots of others. One of the big positives for law enforcement, ambulances, et cetera, to want to participate in this type of work is that for them to book somebody into the jail, it can take 45 minutes to 60 minutes. That's actually very low compared to many areas. But it can take them up to an hour to bring someone to jail, book them in, 2 officers hanging out, get them through the system. and they come to the sobering center, and instead it's 9 minutes. And that's actually really high. I think it's down to 7 typically. And so we end up having very, very fast. So now they can go out to public safety again. So the officers can get back into the field without standing in line at the jail. And sometimes they would have to go to emergency department instead to bring people to then clear them to go to jail. They can just bring them to sobering because sobering has nurses here. So they don't necessarily need to go to jail just because the person may have a potential like medical thing. Sobering will triage at that point. If they need to go to the hospital, sobering will take care of it. Rainbow Cities or Rainbow Services in Kansas City, Kansas. I visited them 2 or 3 years ago. Just very basic. Like literally, this is one room that has capacity. I think they have a capacity for 12. If someone wants to sit in the chair, they can sit in the chair. If someone wants to lay in the bed, they can lay in the bed. Very, very simple. Oh, I lost my other slide on that. The cool thing with them is they also do a level of crisis receiving. And this is with well space. So this one's out of Sacramento. Similar to the Kansas City program, is they are crisis receiving for any and all behavioral health. Similar to San Jose, but even more expansive. San Jose, the mental health crisis often comes through the crisis receiving on the same campus, and then they send them to sobering. Here in Kansas City and the well space program in Sacramento, law enforcement can just go straight to the program itself with any and all behavioral health issues. Are they having a moment with their schizophrenia is kind of acting up a lot, but they're nonviolent ideally? Or is it meth? We don't know. Is it a combination of both? Doesn't matter. Bring them into the same location. And with this approach, is law enforcement doesn't have to make this decision in the field of whether or not this person is better for, should I send them to the step-down psych facility? Should I send them to door crisis, for example, in San Francisco? Where should I bring them? One door, walk in. Many more places across the country are starting to do this. And the nice thing is you don't have to tease out either in the care that's provided or the decision to bring someone there based on what they have going on inside. Once the person starts hopefully sobering up a little bit on whatever intoxication that they're on, they become more engageable, and then we'll be able to work with them. Some of the higher level services, such as Kansas City, has nurse practitioners on site and that can actually give them medication to help them calm down, to help them be able to sleep and rest. So they don't have to be stimulated the entire time. They can actually give them some medication if the client wants. It isn't a forced thing. It's not like an inpatient psych where a person gets tackled and restrained and hit with Haldol. It's we've got some medication that will help you relax and sleep it off for a little while. Do you want it or not? And they can opt into that. One of the things I will say is that right now there's that huge movement across the US. You've probably heard about the Certified Community Behavioral Health Program, CCBHCs. From my opinion, from what I've seen so far and in conversations with people that are starting them, these certified community behavioral health centers are supposed to be full behavioral health crisis receiving. They are not really taking substance use. They might take some stimulant. They might take the mix of, we can't tell if it's a mental health crisis or if they're on some type of meth or speed, but they're not taking the alcohol intoxication where people are sleeping out for 6 hours. So we are, with the National Sobering Collaborative and colleagues in various areas, are trying to work within their own local communities with these certified CCBHCs to see like what is really your sobering component? What's the substance use component of these supposed behavioral health crisis receiving facilities, and see if we can get alcohol and or opiates a bit more into the picture for these services. We'll see what happens as we move forward. And then I think I have 2 more programs left. David L. Murphy and Sobering is down in Los Angeles. They're right on Skid Row at Maple and 6th Street. And they have a fairly large capacity, around 56 bed capacity. The room on the left-hand side you're seeing there with the yellow chairs, that's the women's dorm. Men looks very similar, except way larger. The men's has capacity of around 40-ish. And then here, the one thing you can kind of see in that back, right in the middle of the screen, there's a little room with glass windows. That is an individual room. So they have 3 different private rooms. Many sobering centers are starting to incorporate this so that an individual, if they need their own space, and it could be very basic, like they've got lice and you don't want it to get on everybody else, but they're too intoxicated to treat it yet, let them sleep it off for a couple hours and then we'll get you in the shower and we'll do the whole treatment. Or it could be something they have a cough. Well, let's put them in there and shut the door, and then they don't have to cough on everybody, and we can still take care of them and see what happens as it moves forward. Two, folks someone snores a lot. Oh my God, if we had an individual room in San Francisco, the amount of sleep apnea that comes in with intoxication is amazing. I mean, my record was there was a guy, it took him 30 seconds to get a breath through his sleep apnea, his chest, just front, no air going in at all. I had some students who were just like, we're just waiting to see. I'm like, this is why we keep people on their side. And as soon as he breathed, we're like, oh, let's just roll him on his side because that took longer than I anticipated. Also had a guy, one of my favorite patients years ago, who sang in Italian every single time he'd come into sobering. And it really disturbed the other clients because he would not stop singing. And he actually sang okay, but who wants to listen to it nonstop? So that would be the perfect client for an individual room. You never know how they're going to present. And the reality is you want to be as low barrier as humanly possible, get them in a room. With Los Angeles, the amazing thing they have going on is they are really, really high-end intensive case management. The team that they have running their peer group down there for their sobering center is outstanding. It's a mental health services provider called Exodus that runs the program. They run a psychiatric urgent care. They have a psych pharmacy. They have other programs. And these peer professionals, it's led, the management is a peer. The whole team is, they get basically 20% of their discharges end up going into some stabilizing program, which, if you consider, you've got folks who are being brought in by law enforcement, ambulances, et cetera, who they're not looking for care at the moment. They're not looking for help. They're literally intoxicated and someone wants to keep them safe, but they bring them to sobering. But 1 in 5 end up leaving to some higher level, which is pretty amazing. It sometimes takes a little while to get someone to that point. But they also can do insurance applications, they can do housing applications, treatment services, and track them. And they, like many other programs, also share the emergency medical record and the electronic health record for clients. So they can kind of see where they go, where their providers are, and get a hold of providers and work with the individual to connect them to the community. And then lastly is Houston Recovery. And they, as you can see, that is a giant room. I was back out of there again in October. They have a capacity for 83, which they have never filled. And so they've converted some of the beds to be, they call them extended stay. I forget what it is, but they can keep people for a few days who are transitioning to a different program if it's going to be a wait to get them there. They also have some folks on light respite, like they have some type of wound or they have a situation going on where really should stay inside, but there's no place for them to go, so they'll keep them here. They have a couple other programs, which I'll skim over, but basically they work a lot with this 18-month program that they have seen outstanding results with. And they started this Partners in Recovery a couple years after the sobering center started, when they had the frequent clients coming in a lot, and they provide ongoing support for these individuals to try to get them into care, MAT programs, et cetera. And then the sobering staff themselves work directly with the referring providers to provide training on everything from trauma-informed care to their work, overdose prevention. And so they are engaging with the providers themselves to help get law enforcement more on board with the reality of this work. And they take from, I think, 82 different law enforcement agencies can bring into their sobering center. And just as a quick shout out to data, 2010, there was over 20,000 public intoxication bookings in Houston. Just Houston, 20,000 people arrested and booked for only intoxication. The conversation around then was when they were looking at starting sobering. And so they started talking about it. The numbers went down a little bit anyway, but the third blue line, you can see over 15,000 bookings that year for intoxication. And then they opened up the sobering and it started getting orange. Folks started going into the Houston Recovery Center. And so between 2010, with 20,600 encounters being booked into jail, went down to 835 bookings into the jail 7 years later. Now, is there an equal amount of 15,000 all the way across and just shifts? No. Do we know why? Not necessarily. Some of it could be because they started really wrapping around and sobering was able to get people into other services, so they were stabilizing a little bit better. But regardless, it has been kind of a fabulous thing of getting this law enforcement to really, and they have a really, really good relationship with them throughout. And then lastly, SPOT program. So this is opiate specific, 8 a.m. to 8 p.m. out of the Grayson Center in Boston. And you can see those beautiful vital signs, 87 over 55, 65 over 31, but the oxygen level was great. And a 38 pulse and a 50 pulse. These are folks who self-present or law enforcement can bring them in for using opiates in the field. That's the dorm right there. It's this little tiny room. They got like 12 lazy boys that do not match, which they say they will never do again because clients get a favorite chair, but then they come in for a visit and someone else is in their favorite chair. It causes issues. So they say they'll get matching chairs next time. They have perfected the art of getting folks in with opiates, and they almost never have to use naloxone anymore. The cocktail that people are on is a mix of an opiate, benzo, clonidine, Phenergan, and GABA. It's like this thing that people in the streets in Boston are using as their drug of choice, this combination. Bottoms out the blood pressure, bottoms out the pulse, and obviously causes the respirations to go down. And they found that by just putting 1 2-liter oxygen via nasal cannula on, and potentially giving naloxone at the beginning, they'd give like a quarter dose of naloxone, they titrate it, that they could get the oxygen up enough, the respirations up enough to get the oxygen around, and the blood pressure and pulse didn't even really matter. They still stayed super low, but the person never had to go to the emergency department. And now they've almost stopped the naloxone. They really don't have to give it, and it's just that oxygen via nasal cannula, keeping them a little bit upright in the chairs, and they can keep people for hours. The other cool thing with them is they get a lot of women coming in the door who are, they're the only sober I know that has way more female presenting individuals who come in because they feel safer and they're getting assaulted less in the street, because when they decide to use, they can come into the sobering center instead, and they're not getting assaulted in the street. They have a great exit process to get people out of the program because it's only open during the daytime. And I've seen them do presentations. And I went to one of the staff at a workshop at the Immersive conference this fall. And, you know, they're like, it's like an hour before closing, they'll start some music that's a bit mellow. And then the music will become a little bit more upbeat, maybe 20 minutes later. And they start the lights will start going, I get little dimmer switches and the lights will start going up, so that within a half an hour of them closing, the lights are up, the music is playing, they've got drinks out for everybody for water and electrolytes in case they haven't had anything yet. The snacks are ready. Folks do their thing, and then everyone's out the door and they close it up for the day. Probably does it go smoothly every time? I can imagine it doesn't, but they've worked it out, and they've been doing this for, I don't know, 8 or 10 years now. Last couple thoughts. There's a lot that goes into sobering and making it as efficient as humanly possible. Right now, law enforcement doesn't seem to have as many issues of bringing in. There are some considerations around just making sure the individual has verbally consented to going to sobering versus going to jail. Alternate destinations for ambulances is where the big hurdle is. Every state is totally different. California is totally screwed up. We're on our 6th bill right now. We have 1 bill in, but nobody's been able to use it because it's very difficult based on all this naysayers and the people who kind of took it over, and yeah, it doesn't work. We're working on it. There's no ambulance can only be paid if it goes to an emergency department. Doesn't get paid if it goes anywhere else. So police doesn't matter. You don't get paid anyway. Reimbursement for sobering visits. So we now have in California and Maryland, the Medicaid in Maryland do pay reimbursement for individuals to go to the sobering center instead of going to anywhere else. And it covers any sobering visit, from a walk-in to law enforcement drop-offs, whatever. If they're in sobering, it'll be reimbursed on Medicaid. Right now, we're kind of figuring out how community paramedicine fits in. That's in the weeds. If anyone wants to ask, we can. The other big thing is, especially everything that's been going on in the world right now, navigating the criminalization of individuals with intoxications varied everywhere. It's illegal in California. It's not illegal in Houston or Texas. Homelessness is now, it's more acceptable to criminalize homelessness. So how do you work with the sobering and try to get people there who are experiencing homelessness so you can kind of keep them out of everything else? And then the reality is even if you have the best sobering program in the history of mankind, if you don't have any place for anyone to go, you don't have shelters, you don't have housing, you don't have treatment programs, there's only repeating the cycle. is what the option is. And so how do we keep people safe? As one of the medical directors of the homeless outreach team in San Francisco many years ago had said, he's like, our work is basically just trying to keep people alive long enough for the system to change. And I think that's some level of what sobering does, is like, we are, all of us who are in this work, I would say almost every program I know of is actively working in the local or regional or even state communities to change this regulation and policy. And it's still a long way to go. So there's, if you know people who want to start a sobering center, we have all kinds of amazing things. And I'd love to shout out to the third bullet, which is the SAMHSA Behavioral Health Crisis Guidance. SAMHSA puts out their definitions of what behavioral health is in the country and all the different things that you can do to work with it. We are now finally featured sobering care for the first time in their things, 4 pages there, and then we're in a couple other spots. SAMHSA has been very active in working. They've come to my last 2 conferences that we've had. Our national sobering has had, we just had our 6th national conference was in October. We developed standards of sobering care now that are like, if someone wants to do sobering, we have standards from training of staff to what kind of bed capacity you should have, et cetera. We do monthly Zoom care provider meetings with different presenters. SAMHSA was supposed to come next week, but obviously with the overchange of administration anyway, there's always an, what do they call it? I forget what the name is, but where everything slows down for 2 or 3 weeks, we just happen to plan it in the middle and forgot. So SAMHSA, we're kicking them to like June. They're going to come and present to us and talk about their work with crisis receiving and how sobering kind of fits into it. We have toolkits and we have all kinds of protocols and a website and news and research and stuff. That is me. And that is a photo I took in San Francisco when I was learning how to do some photo editing, and that was fun. I did it. And then I will end show and stop sharing, and hopefully that stopped. It did. Excellent. So I don't know if I gave us enough time, but man, I talked a lot. And I will stop talking and hand it over back all the y'all.
That was wonderful, Shannon. Genesis, could we pause recording just to provide folks